Hi, my name is Diane Nowak, and I'm a registered dietitian that specializes in nutrition support for critically ill patients. This course is just one in a series of modules on indirect calorimetry brought to you by Channel 1, On-Demand Nutrition Education. This module is part 4 in a 4-part series. We are focusing on adult patients today. Today, we are looking at applying indirect calorimetry results to the nutrition care process. We will look at interpreting feeding adequacy, review 2 case scenarios, and apply the indirect calorimetry results to the care plan. And then we'll discuss methods of communicating IC results. When we look at critically ill adult patients, we should recognize the phases of critical illness. There are 3 phases of critical illness. The first is the ebb phase or the shock phase. This is within 24 to 48 hours after injury or surgery. Here the goal for nutrition is metabolic support. The second phase is the early flow phase, which is our catabolic phase. This is anywhere 3 days post-injury or stress or illness. The nutrition goal remains the same, and that is metabolic support. The third phase is the repletion phase, which is also known as the late period of flow phase. This is where you'll see anabolism. These are anywhere from days 10 to 60, but can last even longer. Patients may need up to 130% of their resting energy expenditure to support tissue repair, repletion, and recovery. Our nutritional goal shifts from a metabolic support to promotion of repletion. In this graphic are practical guidelines for nutrition support from the acute phase all the way to the post-discharge phase. The acute phase, which is days 1 through 4, and the post-acute ICU phase is greater than 5 days. This is where you'll see early mobilization. It is in the post-acute ICU phase when many organizations perform indirect calorimetry as a protocol on day 4. Nutrition support is progressed to prevent overfeeding and to evaluate for refeeding syndrome. On day 1, patients are started on nutrition support at 25% of the calories per kilo target. The nutrition support is increased by 25% on days 2 and 3 as long as there was no refeeding. On day 4, then, the indirect calorimetry test is performed and the nutrition support is adjusted to meet 100% of the measured resting energy expenditure. Propofol, glucose, citrate, and other non-nutritional calories are accounted for to prevent overfeeding. If the patient is discharged from the intensive care unit, this is where the target remains until they enter the post-ICU phase, which is where exercise begins. In this phase, calories can be increased by up to 120% of predictive equations or 125% of indirect calorimetry results. I should note that there are no formal recommendations or guidelines for this phase. Optimal calorie and protein intake is necessary to enhance recovery. Indirect calorimetry studies during the recovery phase demonstrate a marked increase in metabolic needs, with total energy increasing as much as 1.7-fold above resting energy expenditure. And then the last phase is the post-hospital discharge phase. This is the rehab phase, where there can be an increase in calories by 150% of predictive equations or indirect calorimetry. How do we look at interpreting feeding adequacy in adults? When we're underfeeding, this leads to negative outcomes, including malnutrition, impaired recovery, and increased mortality rates. With overfeeding, this leads to complications such as insulin resistance, hepatic dysfunction, delayed weaning from mechanical ventilation, prolonged ICU stay, and increased mortality. Feeding adequately means we're providing adequate calories to support metabolic demands, preserve lean body mass, and to prevent muscle wasting. Calories delivered to patients during the acute phase of their critical illness should match measured or estimated energy targets despite the ongoing endogenous nutrient release, which is not suppressed by feeding and remains immeasurable. The effect of non-nutritional calories, including propofol, glucose, and citrate, should be taken into account when determining the target exogenous energy dosage. Our first case study today is looking at a liver transplant patient. This is a 52-year-old man with metabolic dysfunction associated liver disease, cirrhosis, who reported to an outside hospital in March. One day after admission, the patient One day after presentation to the outside hospital, the patient had a PEA arrest. This patient was transferred to our organization on the same day and underwent a TIPS procedure. The patient was then listed for an urgent liver transplant evaluation 3 days after presentation. The patient underwent a donation after breath death liver transplant with exteriorized bile ducts 4 days after listing. Patient then did have his biliary repaired 3 days after the transplant. With the patient having a prolonged respiratory insufficiency, he did undergo a tracheostomy 9 days after the transplant. The liver function test remained high. Our patient had to undergo a transjugular liver biopsy, which measured his pressures, and those remained high. Our patient was relisted for liver transplantation. 1 month after his first transplant, a second liver transplant evaluation due to graft dysfunction was completed, and 5 days later he was listed for a liver transplant and had a repeated transplant 2 days after that listing. Our patient experienced repeated GI bleeding and underwent a sigmoidoscopy, which showed low-flow colonic ischemia. Our patient returned to the OR for exploration multiple times within 2 weeks after transplant, 5 days later, and 16 days later. If you look on the graph, our patient's weight that we used was 115 kilograms. We estimated his caloric needs to be 2,875 or 20 calories per kilogram following the ESPN guidelines. And this assessment was done shortly after his admission to our hospital. That is the star that you see on the graph. Our patient was started on TPN on presentation to our organization, and he was on TPN for a month. He was transitioned to enteral nutrition support for 3 months. Unfortunately, he then was placed back on TPN for about 15 days before we could transition him back to enteral nutrition support, and he continued on that for 1 month before his discharge to a facility. At our organization, we do add 13% to our measured energy expenditure when our patients are on continuous renal replacement therapy. Our continuous renal replacement therapy provides no calories. This is not standard and something that we are investigating at our organization. With every indirect calorie measurement that you see on the graph, the macronutrients in the patient's TPN was adjusted to be sure to meet the measured resting energy expenditure. Our TPN is not stopped in our intensive care units. There was a big change in the patient's measured resting energy expenditure where the calories went from 1,707 to 2,639. The ventilator was in CPAP mode when he was tested at the higher calorie level of 2,639. At the lower calorie level, our patient was on pressure control ventilation, where the ventilator controls all phases of the breath. So it may be that the mode of the ventilation being CPAP is what caused the increase in caloric needs, as the patient required more work of breathing on his own. When the patient was on enteral nutrition support, at times there were suboptimal intake, and the dietitian decided to focus on volume-based feedings and ordered a higher rate to achieve the daily goal volume. The dietitian followed up every 3 to 5 days to ensure that the enteral nutrition intake did not lead to overfeeding. Out of all the indirect calorimetry testing done that you see there on the graph, 2 times was the feeding plan not adjusted, and both times was when the patient was on enteral nutrition support. The RD will use the measured resting energy expenditure obtained from the indirect calorimetry to adjust our feeding plan, reviewing actual intakes versus what is prescribed. No activity or stress factors are added to that number, with the exception of a patient being in the acute phase. Our second case study is a lung transplant recipient. 35-year-old male with a history of leukemia who underwent an allogenic stem cell transplant several years ago. After transplant a year later, the patient had graft versus host disease in his eyes, skin, joints, and lungs. The patient was admitted recently to an outside hospital for hypoxic respiratory failure. He was then transferred to our organization for consideration of lung transplant and possibly cannulation on an ECMO circuit. On the day of admission to our organization, the patient underwent veno-venous ECMO cannulation. Our patient 2 months later did undergo a successful lung transplant with veno-venous ECMO. Our patient was decannulated from the ECMO circuit 3 weeks after the transplant. If you look here on the graph, our patient weighed 61 kilograms, which was his lowest dry weight. We estimated his calorie needs to be 1,830 to 2,130 calories, or 30 to 35 calories per kilogram. Our patient was started on enteral nutrition support plus or minus an oral diet for 3 days from his admission to our organization. After the ECMO cannulation, our patient was on enteral nutrition support only for 3 weeks, and then transitioned to total parenteral nutrition support for 4 days, and then was transitioned back to enteral nutrition support 1 month after admit. Currently at our organization, we are not testing patients that are on ECMO circuits. Testing on ECMO circuits can be achieved. There are many articles in the literature to support that, and something that we're looking to do in 2026. Prior to our first indirect calorimetry test that was done after ECMO decannulation, the patient was on enteral nutrition support and was receiving daily goal volume that provided 2,160 calories per day with use of a 2.0 polymeric formula with a protein modular added. Our first indirect calorimetry result that you can see there on the graph was 1,372 calories. With our patient being fed well, the enteral nutrition support rate was decreased to provide 960 milliliters or 1,440 calories using a 1.5 peptide-based formula. With the next 3 indirect calorimetry results that you see on the graph, The tube feed rates were adjusted based on reviewing the patient's actual enteral nutrition intake versus the prescribed enteral nutrition intake. If the patient's actual intake was not optimal, the dietitian added an additional 10 mLs per hour to what the goal rate would be, or basically using a 20-hour day instead of a 24-hour day to calculate the target goal volume. We benchmarked at our organization several years ago that enteral nutrition support is held 4 hours per day on average across our hospital ICUs. In this patient's case study, the dietitian decided to base on actual tube feed intake to not change the rate and continue to feed at the higher rate to meet the daily goal volume. This infusion at a higher rate continued for most of the patient's current hospital admission. With concerns for a bronchopleural fistula in early September, no further indirect calorimetry testing was done. The dietitian went back to using calories per kilogram, but keeping in mind the prior indirect calorimetry testing results. When interpreting and communicating an indirect calorimetry result, you do want to use the measured resting energy expenditure to adjust the feeding plan. There is no need to add an activity or stress factor unless the patient is in the post-acute phase. It's important to review the intake records to assess if the feeding plan needs to change, especially for enteral nutrition support. Always discuss the measured resting energy expenditure in relation to the feeding plan with the ICU team. I feel it's important to have in-person conversations with the ICU team so that all can come to an agreement on the feeding plan moving forward. Dead space does impact measured resting energy expenditure. Dead space is any additional parts in addition to the recommended Baxter Cosmet parts that is placed between the connection for sampling on the filter and the patient's circuit Y connector. Every 15 mLs of dead space equals a 3% underestimation of measured resting energy expenditure. The more dead space and respiratory frequency, that error increases. You should also evaluate patient safety and/or ventilator management before removing any extra dead space. How often should you repeat indirect calorimetry testing? In critically ill patients, energy deficit has been associated with increased morbidity and mortality. Per Singer et al., with an anticipated length of stay of less than or equal to 5 days, testing should be done once per week. With an anticipated length of stay of greater than or equal to 7 days, testing should be repeated 2 to 3 times per week. Aspen recommends testing more than once per week. Indirect calorimetry overall should be repeated with changes in clinical conditions or changes in the phase of critical illness. I would encourage you to watch over the videos in the Indirect Calorimetry Channel 1 series to learn more from my esteemed colleagues. I thank you for your time today and have a great day.